see my screen?
Yes, we can.
Okay, good. Okay. First of all, I would like to say to greet Dr. Min Fu, the president of Radiology Society of Kanto, University of Medicine and Pharmacy, Prof. Bao Quan, president of Ultrasound Society of Vietnam, and of course, last but not least, my beloved Dr. Dang Nguyen, and all the lecturer or specialists, radiologists who are present today. So thank you very much for this invitation. I'm very glad and very honored to be here. Hopefully, I can share some of our experience. So our first topic is imaging and intervention in pediatric vascular anomalies. Okay. So first, this is my outline. I would describe or briefly describe vascular anomalies classification based on ISSVA classification. Then I would go into the imaging option and imaging workup, imaging features of vascular anomalies, treatment, and of course at the end I would include a bit of my a few of cases which are a bit challenge to us. Okay. As you know, based on ISSVA classification, vascular anomalies can be divided into two. Number one is vascular tumor. Number two is vascular malformation. Vascular tumor are basically due to proliferative neoplasm, and it due to increased endothelial cell turnover, and this is what we call vascular tumor, so that all the names are end with OMAS or OMAS. For example, hemangioma. So all the name of the vascular anomalies which end with OMA, they are vascular tumor. The other one is vascular malformation. They are not neoplasm. Structural abnormalities of the capillaries, venous, lymphatic, arterial system that grow proportionate to the child. Okay. We divided into two, vascular tumor and vascular malformation. Vascular tumor, for example, hemangioma, which can be divided into infantile hemangioma and also congenital hemangioma. And congenital hemangioma is further described or divided into rich niche, which is rapidly involuting congenital hemangioma, and also non-involuting congenital hemangioma. And of course, tough hemangioma, Kaposi hemangioendothelioma, and pyogenic granuloma. These are not limited to this list only. If you go into ISSVA website and you look at the ISSVA classification, you will see more. But for the benefit of simplify this presentation, I list down a few of the vascular tumor and also vascular malformation. So vascular malformation, which include capillary, for example, port wine stain, dermatologic capillary dermatologic lesion, superficial, and these are usually treated with laser treatment. Okay, but these are not really related to radiology directly. The main vascular malformation that we are seeing frequently are lymphatic malformation, venous malformation, arteriovenous malformation. And sometimes patient presented with mixed malformation. For example, capillary venous malformation, capillary lymphatic malformation, lymphatic venous malformation, capillary lymphatic venous malformation, capillary AV arteriovenous malformation, and capillary lymphatic AVM malformation. So these are due to anomalies of major named vessel, and then some of the vascular malformation are associated with other anomalies or syndrome. For example, KLIPPEL-TRENAUNAY syndrome, Parkes-Weber syndrome, Sturge-Weber syndrome, and Clove syndrome. Okay, but for today's presentation, I will focus all the the lesion which are highlighted in blue, and we will go through into each of the malformation and also vascular tumor. What about imaging option? What are the imaging option that we can do? Number one, radiograph. Radiograph are very limited because radiograph can only see a bone changes, calcification, and phlebolith if there is any. If they don't have any, then they will not see any changes. Okay, I may need to ask, are you clearly listen to me, or there is a problem, some technical problem? Hello, Dr. Deng.
Yes, thank you, Professor Hamzani. If possible, can you increase a little bit the volume? Then it will be clearer.
Hold on, let me see. Okay. Speaker.
Okay, we try to increase the volume in our speaker here.
Okay. Now, can you hear me?
Yes.
Is it okay?
Yes, better.
Okay. Okay. So sorry about this.
It's okay. No.
Okay. So shall I continue? Dr.
Yes,
Dan?
please.
Okay.
Yes, please.
Next imaging modalities is ultrasound. Ultrasound is quick and cheap. I usually will do ultrasound first before I do other imaging modalities in pediatric patient. So number one, ultrasound would be a very quick assessment to differentiate between whether the lesion is solid or cystic. And we can also put color Doppler so that we can see whether the flow pattern, is it a slow flow? Is it high flow? Is it compressible? Is there any phlebolith? And one best thing about ultrasound, it does not involve with ionizing radiation, and especially when you are doing imaging in children. Okay, so next is MRI. Our next step of imaging modality usually MRI, although some patient may have a CT scan, but if the center that you are working does not have MRI, then CT scan will be a great imaging tool. So basically to look at the cross-sectional imaging of the lesion. So this is important because MRI or CT would be able to differentiate whether there is any lymphatic malformation, venous malformation, or a arteriovenous malformation. Not only diagnosis, but it also can assess the extension of the tumor. So the tumor can be assessed properly. Next is angiography or venography. Before we start any treatment, for example, venous malformation, then we would inject a contrast to see whether there is any large draining vein that draining the venous malformation that we see. And angiography is also used to do sclerotherapy. It's also used to do embolization in the case of arteriovenous malformation. Okay. Okay, imaging workup, as I mentioned, we usually do ultrasound first, and we decide whether this is a tumor or is it a vascular abnormality. If it is vascular abnormality, we decide whether there is a high flow tumor, a high flow lesion, the flow is arterial flow, or is it a venous flow? If it is arterial flow or high flow, then we have to see whether, then we will do MRI. MRI will differentiate whether this is mass or is it just engorged or enlarged vessel. So if it is a mass-like lesion, then most likely it is hemangioma. If it is no mass but just a tubular dilated vessel, then it is most likely arteriovenous malformation. And we can also assess the communication or nidus of this AVM. If it is slow flow, then MRI would be able to see whether there is any enhancement, whether enhancement is seen within the lesion or enhancement is seen outside or at the septa or the wall of the lesion. So if the enhancement is seen at the wall or there is no enhancement, then it is most likely lymphatic malformation. If the enhancement is seen within the lesion and you can see there is a tubular structure within that lesion, then this is most likely a venous malformation. MRI finding. T1 if we are talking about hemangioma, they usually iso-intense or slightly hypo-intense to the rest of the muscle. And T2, it is usually hyper-intense. And post-gadolinium, usually they will enhance intensely. In AVM, they have they usually hypo where they have a flow void, because the flow within the lesion is very high flow. Then we will get a flow void artifact within the lesion on MRI. Similar to T2, we will also have a hypo-intense signal or a flow void within the lesion. And if we give contrast, all this tubular structure or flow void structure will enhance intensely with gadolinium. In a case of lymphatic malformation, because it is cystic, so it will not, it is a low signal on T1, hyper intense on T2 because it's fluid and it has no enhancement, or if there is any enhancement, it should be enhanced at the periphery, at the wall, or sometime at the septa of the lymphatic malformation. For venous malformation, they are usually hypo or iso-intense and may have some phlebolith within, which is hypo-intense on T1, hypo-intense on T2. Venous malformation itself will have hyper-intense on T2, and when you give contrast, it will enhance within the tubular serpiginous venous malformation. Okay. So now we go to vascular anomalies, which mainly we will talk on the tumor. Number one is hemangioma, which can be divided into infantile and also congenital hemangioma. Infantile hemangioma, it has overlying patch of skin redness. Sometimes mother will tell you just like a mosquito bite. And in infantile hemangioma, the lesion is not seen during birth, or at birth, there is no lesion there. But the lesion usually appear a few weeks after delivery as a dot of redness, just like a mosquito bite, and it increasing rapidly within the first few months. So the natural cause of the lesion is basically divided into 3 stages. Number one is proliferating stages, and usually occur the first years. And sometimes it may extend into the second year of life. And after that, it's called involuting phase, where it occurs a few years until it involuted and resolved by age of 5 to 6 years. So you can see this graph. It looks like this graph. I mean, it goes rapidly and then it slowly coming down and resolved by 5 to 6 years. But sometimes the lesion may not resolve and become fatty, or there is some residual swelling there. The other division of hemangioma is called congenital hemangioma. It is rare compared to infantile hemangioma. It present at birth, and it can be divided into 2 types: rapidly involuting congenital hemangioma and resolved by 1 to 2 years, and non-involuting congenital hemangioma. Just like in this graph, in this image, you can see it is present at birth and it is involuted by 1 or 2 years. So this is rapidly involuting congenital hemangioma. Imaging for hemangioma, number one, history and photography is very, very important. Diagnosis can be made with history and photo. So imaging will be a bit confusing because it will depend on which phase that you are imaging the lesion. If you are imaging the lesion during the proliferative phase, then the lesion may look like AVM or high flow lesion. If you are scanning the lesion at the involuting phase, then you may see something very benign, fatty changes of the lesion. Okay, this is the example of the patient that I showed you earlier. You can see that at birth there is nothing, but it starts with just like a mosquito bite, and then it increasing as the patient grows. The increase in the increment are mainly within the first years. Okay, so this is ultrasound imaging of the hemangioma. We can divide it the phase into, this is more divided into three, but basically the one that we are seeing clinically is during the last three phase. So prodromal, usually you see a red dot, so maybe we thought this is mosquito bite. And if you do ultrasound, you don't see anything significant. And in early, you'll see increased thickness, redness, and swelling. If you do ultrasound, you probably see hypoechoic center with beginning of hypervascularization at the margin. And during the proliferative phase, so basically what you see a tightly packed vessel feeding the tumor artery, feeding the hemangioma, multiple AV shunting, and also draining vein with arterialization flow. So this is what may confuse us with AV malformation. During the maturity, there is reduction of central vessel with declining arterial flow, more hypoechoic tissue, marginal ectatic draining veins. And during regression or involuting phase, then you'll see a circumscribed hyperechoic lesion. These are basically a fatty replacement. This lesion has been replaced by fat. Only rarely you see central vessel and reduced draining vein. These are example of ultrasound. This is done during the early phase, the proliferative phase. You'll see vessel, the arterial and also venous vessel, and you see a large draining vein at the lesion. And in follow-up, you see that dilated, a lot of vessel has reduced, and now you see more fatty tissue. And at the end of the follow-up, you'll see more fatty tissue with one or two or probably no vascular within the lesion. This is involuting or involuted phase, maturity phase. Yeah. So what is the treatment of hemangioma? Depending on the location and or whether it is involved a vital organ or not. Number one is observation, because if you look at the graph, if you look at the graph that I showed you earlier, it will regress and become, the swelling has disappeared. So observation number one, if it is not in the important vital organ, then we observe. If it is in the vital organ or if it is in the phase where the parents are very worried, then we have started a patient on propranolol. And it has shows, this is example of a patient who had a swelling at the nose with some deformity of the nose. If you look at the nose here, there's deformity of the nose, and the parents are very anxious and very worried. And this is a photo where we have started a propranolol for about a year or so. Then the lesion has become involuted or become small faster. If we wait, then it will disappear on its own, or it become improved without any treatment. Okay, vascular anomalies. This is based on the other thing that I would like to highlight is Kaposi hemangioendothelioma. This is a 2 months old baby girl who presented with increasing right forearm swelling since birth. He was referred to us from a private hospital for orthopedic treatment. And if you look at the ultrasound, there is thickening, heterogeneous subcutaneous tissue. This is a muscle layer. And when we put color Doppler, there are engorged vascularity within this subcutaneous tissue, and a lot of vascularity. So we did MRI. You can see this is T1 and this is T2 MRI, and this is T1 without contrast, and this is T1 post contrast. You can see the subcutaneous tissue has shown some enhancement within the subcutaneous tissue. And after 1 month, so we treated the patient with sirolimus based on the diagnosis of calposiform hemangioendothelioma. Based on ultrasound and MRI, we diagnosed the patient as a calposiform hemangioendothelioma. Started the patient on sirolimus, and this patient had a biopsy done, and it confirmed a calposiform hemangioendothelioma. So after 1 month, you can see that this patient is actually presented with Kasabach-Merritt syndrome, and the platelet was 8 during the presentation. And as the patient treated with sirolimus, it increased, the platelet has increased to normal level. Okay, now we have done with a tumor, vascular tumor. Now we go to vascular malformation. Okay, vascular malformation, number 1 is lymphatic malformation. Lymphatic malformation is actually a collection of lymph field channel. It present at birth. It may be recognized or may not be recognized, and it may be recognized later on after a few months where the swelling has become big, and sometimes you see at birth. Okay, so the swelling will increase with infection or hemorrhage, and the consistency is soft with no overlying skin rashes or skin changes. Most of the time, it occurs in the neck, head and neck, extremities, axilla, and trunk. So complication is infection, bleeding, and also compression to other important organ. If it is in the surrounding the airway, it may cause some compression of the airway. So imaging workup, if you see, you put color Doppler, you put ultrasound, you see cystic lesion, then most likely this is lymphatic malformation. I usually do MRI to basically look at the extension, although I know on ultrasound this is lymphatic malformation. But if it is occur in the neck, then I want to know whether the airway is compromised or not, because I want to plan my treatment beforehand. So I will do MRI. So when I do MRI, what I see is basically no enhancement, or if there is any enhancement, it should be just a wall enhancement. So lymphatic, as I mentioned, hypo, hyper, and also no enhancement. So this is T1, low signal intensity. T2 is a cystic, so it is bright, hyper intense signal. And in post contrast, you can see it has no significant enhancement, and probably enhancement is seen at the septa. What is important to do cross-sectional imaging, either CT or MRI, is basically to look at the extension. So like this one, the lymphatic malformation has extend posterior to the airway, posterior to the larynx. So it may cause some airway compromise, especially when you treat the patient, and this lesion will increase in size for a few, one week or 2 weeks. Then we have to prepare patient airway properly. So imaging, so basically ultrasound shows cystic lesion, no color flow within the lesion, and lymphatic malformation can be divided into macrocystic or microcystic, although some people describe or define macrocystic as more than 2 centimeter, microcystic less than 2 centimeter. But I usually, as long as I can puncture the lesion, I would consider that as macrocystic. And if it is, I cannot puncture, it is microcystic. Okay, so for example, this is a macrocystic. You can see large cystic lesion, and this is microcystic. Sometimes it may look like an echogenic structure, but if you look carefully, you will see there is small, tiny lymphatic channel within this lesion. And this is a mix. This is microcystic, and this is macrocystic. Okay, so treatment of lymphatic malformation is sclerotherapy. We have done with OK-432. Now we are doing with bleomycin. We also have some experience giving doxycycline and also alcohol. Our sclerotherapy are usually done under ultrasound guided, but sometimes we may need a fluoroscopy to assess the lesion before we give sclerotherapy. How do we do it? So we do ultrasound, we puncture this the needle that puncture into the cavity or cystic cavity, and then we aspirated the cyst, and then after that we inject bleomycin or OK-432 into the lesion. And these are some of the response of our patient. This one patient presented with a huge neck swelling, and then after treatment it become almost no swelling, only some skin changes there. And this patient had a huge thigh or perineum or groin lesion. After 2 injections, the swelling has reduced in size, and initially patient unable to wear trousers, but now he can wear trousers. Okay, next is venous malformation. Venous malformation is thin wall, dilated veins, and usually it present at birth, and sometimes it may be hidden in the structure, certain structure, and only appear a few months or a few years after that. And it is a soft bluish skin discoloration of the lesion, and then it is usually compressible, and unless there is a thrombosis within the venous malformation. So venous malformation may be increased, may be reduced in swelling based on whether it is thrombosis or whether there is any infection or not. Okay, so imaging wise, X-ray, you can see here there is a phlebolith. You can see a swelling at the elbow and forearm, left elbow and forearm. On T2 MRI, you can see bright signal with multiple phlebolith within. On ultrasound, you'll see heterogeneously hypoid structure, which is compressible. Ultrasound, what is the best with ultrasound is you can do compression while you are imaging the patient. And this is phlebolith, and CT show sometimes may show a calcified phlebolith. Okay, so ultrasound features lobulated heterogeneous lesion, and usually lobulated, and it is compressible. See this one, this is the lymphatic, this is a venous malformation, this is without compression, and this is a compression, and a phlebolith, and then there is no color flow. This is the flow within the adjacent vein, and also the flow. Sorry, this is a flow within the lesion. The flow are usually venous flow. Okay, so how do we differentiate this lesion with lymphatic malformation? As you can see, that lymphatic malformation has cystic aspirated. Then if you puncture the lymphatic, the venous malformation, what you'll get is this is a venous blood. So this is a lymphatic malformation. This is a venous malformation. Okay. 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 Treatment. Of course, venous malformation, we give polydocanol alcohol. Although some center has STS, sodium tetradecyl sulfate. Some center also give hydroxyacryl glue or bleomycin, but in our experience, we have done with polydocanol alcohol and bleomycin. So usually done under ultrasound guided or fluoroscopy guided, in some cases where it is very complex, the venous malformation are everywhere and involve a deep organ that we cannot go in or we cannot puncture, then we start with sirolimus treatment. Just to highlight, this is the lesion, we puncture with, this is the needle, then we inject alcohol inside the lesion. So, okay. And example of my patient who had a swelling here, MRI was done, shows multiple hyperintense signal with a phlebolith inside. One of the cystic cystic component here has phlebolith. And on ultrasound, it is compressible. This is without compression, this is compression, this is without compression, and this is a compression. So we know that this lesion is compressible, and there is a phlebolith on MRI, and the color flow, the flow within this lesion is basically a venous flow. So this is the treatment that we did. We give alcohol, we puncture the lesion, put a contrast first, identify whether there is a large vein, a draining vein or not. Then if there is no large draining vein, then we inject with alcohol. And this is a pre-sclerotherapy, and this is post-sclerotherapy. Patient very happy. And now patient's supposed to see me again, but they decide not to come because they said the swelling has resolved. So they are happy. Okay, AV malformation, frankly speaking, I have not involved directly with AV malformation because AV malformation are not my territory. Usually it's done by interventional radiology, adult interventional radiology. Imaging-wise, you see a high flow, arterialization of venous flow because there is a shunting of artery to the vein. So you see engorged arterialized vein, and also sometimes you may see the nidus. So this example of AV malformation was shared by me by Prof Rosman, and you can see this is the nidus. The nidus was treated, and there's no, and you can see there is a early draining vein. Post-treatment, post-embolization, there's no early draining veins. So last is TRENAUNAY syndrome. This is a 4-year-old boy who presented with huge left lower limb enlargement. Patient had embolization in some other hospital, and the limb become engorged and huge. And he is not able to walk, just lie down, and his activity is very limited. So he came to our hospital. Looking at the imaging, we don't think this is a straightforward venous malformation. If we want to treat it is interventionally, it is very difficult because it has a combination. MRI show a combination of venous and also lymphatic malformation. So we diagnose the patient has KLIPPEL TRENAUNAY. And then this is post-treatment, and this is pre-treatment. This is post-treatment, and this is pre-treatment. So you can see post-sirolimus, what we give to patient, because we don't think a treatment, interventional treatment would be helpful to the patient. So the patient was given sirolimus, and it caused reduction, significant reduction of the lesion. And now the patient can, of course, the swelling is still there, but he can wear trousers and he can walk. He can walk and do his activity freely. Okay, so do we have time, or shall I conclude?
Okay, thank you, Prof. You can continue. We are still follow.
Okay.
You have
okay.
A few more slides.
I think I already
right?
Yeah, I will this one. I will skip this one. I will go straight to
so
can you give me 5 minutes?
Yeah. How about the tongue IVM? Is it the IVM? The tongue? The patient born in 1951. The lady. We want to follow to see your talk about the patient, that patient, the one with the tongue, the tongue, the tongue, AVM or hemangioma.
Oh, I thought I don't want. I thought I don't want to show that image, but okay. I'll I thought of not showing that lesion, but anyway, okay. So
yeah, the patient was born in 1951. Do you have that patient? Yes, this one.
Yeah, this one. Okay. This is one of the patients who came to us with a huge swelling of the tongue, and he has a problem with articulation, so he cannot talk properly. He has snoring and also excessive drooling, and sometimes intermittent bleeding, especially when he eat something which is hard, for example, chicken bone or other things. So he came to us. I think one of our interventional radiologists has started patient with sclerotherapy, polidocanol, given once, but patient respond quite badly, had a very huge tongue, and the patient need to be admitted to ICU and for observation because the tongue has swollen badly, compromised her airway, and then after treatment with dexamethasone, it improved. Therefore, we thought of we don't think polidocanol or any sclerotherapy would be safe for her. So therefore, after our discussion, we had a multidisciplinary vascular malformation group in our hospital. So we had a discussion on this patient, and at the end, we decided to give sirolimus. So this was a pre-sirolimus, and this is a follow-up post-sirolimus. Not only clinically is improved, but imaging-wise, it also show some reduction of the lesion, and the patient was quite happy because he able to sleep, he able to eat properly, and the husband was very happy. Therefore, that's why the patient was very happy. But unfortunately now, after stopping the sirolimus, the lesion start to grow back. So we are planning to review her again, and then KIV to start back on sirolimus. Okay. So I think okay, I will touch a bit on this patient. Hello? Hello, Dan?
Yes, you can continue. Yes.
Can I continue? It will take a long time, but
yes, okay. We are still listening.
Okay, this is a 45 years old who had a right neck swelling. Initially, we thought this is a lymphatic malformation. We treated the patient with bleomycin. We treated the patient with OK432 and also alcohol, but unfortunately, the lesion has reduced in size but recur multiple times. So at the end, this is the example of before treatment improve and then recur again. So at the end, what I thought of maybe this is not a lymphatic malformation. Therefore, when I did ultrasound, I thought maybe this is actually a ranular cyst rather than lymphatic malformation, because it's very close to the submandibular gland, and I can see a cleft here. So maybe there is a communication there. I'm not sure, but our fistulogram does not show any communication with the submandibular gland. So and if you look at the consistency of the liquid is not as like a lymphatic malformation. It's very, very thick. So therefore, I think I was thinking whether this is not a lymphatic malformation but granular cyst. So what we did is we aspirated this cyst, and then we put a bleomycin inside the cyst, and we also inject Botox within this adjacent submandibular gland. And surprisingly, from February 2022 until April 2022, the swelling has reduced, and there's no recurrence. There's no the lesion has not come back, and the patient was happy because the swelling has resolved. There's no recurrence, so he is happy until now. Okay, so I think I probably stop here, Deng. So I will conclude. So basically, my lecture are based on classification, ISSVA classification, which divided into vascular tumor and vascular malformation. And history is very, very important. History is very important, especially in case of hemangioma, whether it is infantile or congenital hemangioma. Role imaging is basically to establish the diagnosis, to see extension, and to follow up for treatment response. And not all cystic lesions are lymphatic malformation, just like in my patient with the neck swelling. We thought it's lymphatic malformation, but it's actually a granular cyst. Treatment of hemangioma, if it is not involved the vital organ, then observe. You may give some propranolol to speed up the resolution, and rarely you need the surgery. Lymphatic malformation, sclerotherapy. Venous malformation is also sclerotherapy. ABM, we give embolization, and sometimes we give sclerotherapy as well. So surgery are usually reserved at the end. And my experience, most of our patients will not have any surgery. They usually come after their first surgery and then recur, and then they come to us for treatment. And sirolimus is one of the medical treatment that we have tried in complex patient in extensive venous malformation, and it works. And we also try in. Okay, teamwork is the formula. I think you need to work with other team, ped surgeon, ENT surgeon, anesthetist, and thank you very much. Many thanks to my guru, Prof. Zulfikar, and my colleagues who have shared some of their experience with me. Thank you, everyone. Invited to come to my new hospital. This is our children hospital, just beside our adult hospital. Thank you, Dan.
Thank you so much, Professor Hamzani. It is a very interesting presentation I have been heard.
Okay.
So thank you so much for your